at Penn Medicine, which is the hospital of the University of Pennsylvania. He does specialize in scleroderma, among many other GI issues. And he's very kind in helping us out today by doing this webinar for us. Thank you so much, Dr. Ahuja. He went to the University of Virginia, then where else? University of Michigan for med school, right? University of Virginia for residency, and Johns Hopkins for his fellowship. Please join us in welcoming Dr. Ahuja. And if you would, please make sure you're recording.
I am.
Oh, by the way, I'm sorry. The Scleroderma Foundation wants us all to know that this is for educational purposes only. If none of this is intended to replace the advice and guidance of your own physician. Thank you. Dr. Ahuja.
Thanks so much. Good evening, everyone. Thanks for having me. I have a few slides prepared, so I'll go through those. It shouldn't take more than 30 minutes, and then I thought we could open it up for questions. My hope is to be candid with what I know and what I don't know, but hopefully this is instructive. Along the way, if anyone has any advice for reorienting either my register or what we're talking about, I'm certainly open to that. So I'm going to share my screen. Is this visible?
It is now, yes.
Okay, great. I'm going to try to get into.
There we go.
Okay, great. So I have a few disclosures. Just some of the academic work that I do involves industry partnerships. So I just wanted to be candid about that. I usually start my talks with that. Just to outline what I'm going to be talking about today, I tend to think about my work in seeing a patient segmentally, so the various segments of the GI tract, and I'll go through those: esophagus, stomach, small intestine, and colon, with particular attention to potential manifestations and implications for the scleroderma population, and then again conclude with question and answer. So just some broad strokes. GI manifestations are common in scleroderma, as you all likely know. The most commonly involved segment is the esophagus. 90% of patients with systemic sclerosis or scleroderma will have some manifestations of disease in the esophagus. Next, most common is the small intestine, from 12 to 55%, with stomach and colorectal not far behind. Those symptoms can vary from mild to quite severe. They can also vary in their quality. So it could be trouble swallowing, it could be heartburn, it could be regurgitation, nausea, vomiting, early satiety, which means a feeling of fullness, perhaps sooner than one should be during a meal, bloating, distension, diarrhea in the small intestine, constipation or fecal incontinence in the colorectum. And then there can be generalized manifestations as well, such as abdominal pain, malnutrition, and GI bleeding. The pathophysiology of GI disease in scleroderma is not well understood, meaning, what drives the actual pathology. The presumption is that it's a sequence of events beginning with compromise of the blood supply at the level of the microvasculature, complicated by immune-mediated inflammation of the neurons, leading eventually to progressive fibrosis or tissue scarring and dysfunction of the muscle of the gut. So moving into the segments, esophageal disease often is attributed to dysmotility, meaning an abnormality in the movement of the esophagus. There was a study done in 2017 that looked at the most common manometric abnormalities in the esophagus in patients with scleroderma, manometry being this specialized physiologic test where a catheter is placed into the nose along the length of the esophagus to measure how strong or weak the esophagus is and how well coordinated. The most common abnormality is a condition called absent contractility. That's what's shown here. This is what the readout looks like from a manometry. On the left would be a normal manometry, and on the right would be absent contractility. This is so typical in the scleroderma population that it sometimes goes by the name scleroderma esophagus. So in someone who doesn't have a diagnosis of scleroderma, when we see this finding in someone who has difficulty swallowing, we might go so far as to order the autoantibodies that are associated with scleroderma just to make sure that's not the diagnosis that's underlying this. But it's not true across the board in patients with scleroderma. The second most common abnormality, or the second most common pattern on esophageal manometry, is actually normal esophageal motility. And then ineffective esophageal motility is third, which is somewhere in between absent contractility and normal. Along with dysmotility and specifically weakness of the esophagus often comes GERD, which is gastroesophageal reflux disease. This involves both weakness of the body of the esophagus as well as reduced tone of the lower esophageal sphincter, which is the muscle that sits at the base of the esophagus. The lower esophageal sphincter is the body's natural anti-reflux mechanism. It opens periodically throughout the day to let air out of the stomach and to let secretions into the stomach. When the tone is low, it just predisposes to more reflux potentially from the stomach into the esophagus. So for that reason, I often will just presume the presence of acid reflux in patients that I'm seeing for the first time with scleroderma. It's not always the case that it's present, but it's frequent enough that I maintain a high suspicion. We have, fortunately, a number of very good acid suppression medications, proton pump inhibitors, which I'll be talking about periodically through this talk. Things like omeprazole, esomeprazole, lansoprazole. It should be said, though, that because of this mechanical predisposition to reflux, acid suppression doesn't preclude the possibility of non-acid refluxate coming up from the stomach into the esophagus. Unfortunately, there are no medications that are effective prokinetics for the esophagus. Prokinetic meaning medicines that accelerate transit through a given gut segment. There's been research on existing medications like bifenacol, pyridostigmine, and buspirone. They haven't showed a consistent effect in terms of accelerating transit in the esophagus or making contractions more robust. Consideration of anti-reflux surgery in patients with weakness of the esophagus merits extreme caution. Anti-reflux surgery is what we use for patients who are failing high-dose acid suppression medication. You may have heard of a fundoplication, which is taking the top of the stomach and wrapping it around the bottom of the esophagus to create an augmented acid barrier. The problem in patients with weakness of the esophagus is that adding resistance to the outflow of the esophagus will predispose potentially to further difficulty swallowing. So for that reason, recommendations for reflux in scleroderma are often medical and behavioral. So in addition to acid suppression medications, avoiding bulky foods, chewing well, sitting upright while eating, avoiding lying down within 2 to 3 hours of a meal. These are behavioral interventions that are recommended across the board for patients with GERD, just to avoid any other reasons why contents in the stomach might be coming up into the esophagus. Beyond the high-dose acid suppression that most folks know about and that most physicians will reach for as first-line therapy, there are some adjunctive agents that could be considered. Things like baclofen, which is a muscle relaxant that actually has been shown to increase the tone of the lower esophageal sphincter. Not always well tolerated because of headaches as one side effect, but something that can be considered. And sodium alginate is another compound that I will sometimes use as an adjunct for acid suppression therapy. It's in Gaviscon, which is one of the antacids that you might find at the pharmacy without a prescription. Sodium alginate sounds like algae. I think of it as kind of working like algae in the way that algae sort of floats on the top of water. Sodium alginate forms a polymer type raft in an acid pocket, and as opposed to the acid suppression medicine, which turn off the acid pumps in the stomach, this raft provides a mechanical barrier to reflux, which can provide sort of a second layer of protection. So there are a number of testing modalities that can be considered for esophageal disease specifically. The most common ones that we employ are upper endoscopy, or EGD. That stands for esophageal gastroduodenoscopy. Barium esophagram, which is a radiologic test in which patients swallow contrast, and x-rays are obtained to get a sense of the structure and movement of the esophagus from the outside. Esophageal manometry, as I mentioned, and pH impedance testing, which is another specialized test involving an intranasal catheter to formally measure and quantify the amount of acid that's actually in the esophagus over 24 hours. So why would we do a test, particularly in a population where we know there's a high predisposition to esophageal abnormalities? Some reasons why would be you can identify and treat secondary causes of dysphagia. So sometimes stasis in the esophagus due to dysmotility will lead to a secondary problem, such as a fungal infection with a yeast called Candida, or a peptic stricture, which is scarring at the bottom of the esophagus due to acid reflux long term. These would involve therapeutic branch points where we'd follow a different path in terms of treatment. So worth identifying and including those other causes. Some other reasons why people may want to test is that there's increasing concern about the potential side effects of long-term PPI use. My personal take is that those concerns are overblown, that actually the literature from 5 to 10 years ago has been overturned by more rigorous study that's been done recently. So concerns about chronic kidney disease, dementia, bone density loss, I think while quite scary, those have shown not to be very credible long-term side effects of PPI. So I feel comfortable with long-term side effects of PPIs, though there are some that I think are worth bearing in mind, including a slightly increased risk for small intestinal bacterial overgrowth, which is, as I'll talk about, another condition that's enriched in the scleroderma population. So if there's a need to potentially liberate a patient from a PPI, doing formal testing to find out if it's actually necessary is another worthwhile reason to pursue testing. Again, I assume silent reflux until it's proven otherwise. In the rare circumstance that surgical planning is being considered, either for a patient for whom anti-reflux surgery has been deemed a possibility, or for someone whose lung disease merits consideration of a transplant, formal esophageal physiology testing would be worthwhile as well. It's also the case that as I mentioned, Scleroderma esophagus is the most common entity, but it doesn't preclude the possibility of other independent causes of trouble swallowing. So if there are refractory symptoms that are unresponsive to therapy, it's worth checking to make sure we're not missing something else. Achalasia is a very rare problem involving the motor activity of the esophagus that's totally unrelated to scleroderma. But in this series that I mentioned earlier from 2017, the prevalence of achalasia in the scleroderma population was low, but not zero. So moving on to the next segment, which is the stomach. I want to talk a little bit about gastroparesis. Gastroparesis is a word that means something fairly specific. So symptoms of gastric outlet obstruction, specifically nausea, vomiting, early satiety, or again, feelings of fullness mid-meal. In the absence of mechanical obstruction, so a test has been done to exclude the possibility of something physically blocking outflow from the stomach into the small intestine, with confirmed gastric transit delay. And there are a few ways to measure gastric transit, but the gold standard is a gastric emptying test. That's a radiologic test where over 4 hours, a patient eats a test meal that has a radio label on it, an isotope that allows a radiologist to look at it on an x-ray. And at 1, 2, 3, and 4 hours, they measure how much of that meal is still left in the stomach. And if there's more than 10% left in 4 hours, then stomach transit is delayed and a diagnosis of gastroparesis is made. It's worth noting that there are numerous potential confounders for gastric emptying as a quantitative metric. So it's not a very, it's a crude test. Medications can slow transit in the gut. The level of someone's blood glucose at the time of the study can delay transit as well. So worth paying attention to larger clinical context. There are sometimes calls made of gastroparesis on the basis of other more common tests, like an upper GI series, which is a different kind of radiologic test, or an upper endoscopy. I find those to be unreliable tests for emptying delay. So if there's any question about gastroparesis, the emptying study is really the gold standard to follow. I'll say that the stomach is a complicated organ, and so I won't belabor this, but just to say that there are a number of potential pathophysiologic reasons why someone may have gastroparesis. For example, the top of the stomach may not be relaxing appropriately. That's called impaired fundic accommodation. The rhythm of the stomach, it's an electrical organ like any other organ in the body, may be disturbed, so it could be slow or fast, leading to the symptoms of gastroparesis. The antrum, which is the bottom part of the stomach, may be impaired in its mixing, which is normally coordinated. In the setting of gastroparesis, may be discoordinated. There's a subsegment of the gastroparesis population that has dysfunction at the pylorus, which is the muscle that connects the stomach to the small intestine. So there are a few interventions in gastroparesis that we employ that are directed towards forcibly relaxing the pylorus. Distal obstruction, so slowness of the small intestine, can be reflected upward as back pressure, leading to an artifactual finding of gastroparesis. And then sensory neuropathy. So certain patients with gastroparesis have only a mild motor delay. Say they have 11% retained at 4 hours, which is just shy of normal, but they have profound abdominal pain when they eat. It's hard to square that with just a motor problem. And so in that case, it may be that the sensory nerves around the stomach are sending signals of toxicity or distress to the brain in the absence of an appropriate stimulus. I think it's always interesting. So I'm a motility doctor. We think a lot about motility, but at the end of the day, how much does motility matter? I think to the extent that it rules in motility-oriented therapeutics like prokinetics, it's helpful. But there's a movement in the motility community that I think is instructive to think about gastroparesis and its adjacent diagnosis, chronic nausea vomiting syndrome, as two sides of the same coin. So if someone has the clinical presentation of someone with gastroparesis, but their emptying study is normal, should we be treating them very differently from gastroparesis? And the argument, at least in this burgeoning movement, is no, that these are both forms of gastric neuromuscular dysfunction. The nerves and the muscles of the stomach are impaired. Whether or not that rises to the level of a motor neuropathy significant enough to have an abnormality on your emptying study, it's kind of worth what it is, but it still obligates therapy. And therapy is often the same, whether or not someone has a motor delay or not. So I think of treatment for gastroparesis symptoms as happening in 5 major classes. Neuromodulators, which are practically speaking psychotropic medications that we repurpose to modulate the neurochemistry of the gut as opposed to the neurochemistry of the brain. Anti-nauseants, things like ondansetron, promethazine, prochlorperazine, that address nausea at the level of the brain and are sort of agnostic to what's going on in the stomach. Diet is the cornerstone of gastroparesis management, also applicable probably to gastroparesis-like syndrome or chronic nausea vomiting syndrome. And then prokinetics and mechanical interventions, those are the interventions that I would say for people who have a prominent enough motor abnormality to have an abnormality on their emptying study. As I mentioned, diet's the cornerstone of gastroparesis management. Typically, recommendations takes the form of multiple small meals in a day and avoidance of fat and fiber, particularly in solid food, just because those elements will sit in the stomach longer and lead to prolonged feelings of fullness. Those recommendations are not, strictly speaking, data-based. They're mostly theory-based. What is more data-based is the idea of a small particle size diet. So basically anything that you can mash to the consistency of a mashed potato is going to empty out of the stomach better than something bulkier. So smoothies and blenderized foods tend to be better favored in the setting of gastroparesis. Anti-nauseants, as I mentioned, there are some first-line drugs that are relatively cheap and easy to obtain, ondansetron, promethazine, prochlorperazine. There is a whole slew of sort of secondary and more esoteric anti-nauseants that often take a while to get payer coverage for, but can be helpful if the first line fails. Neuromodulators, as I mentioned, are psychotropics, but there are a couple in particular that I think about for gastroparesis. Buspirone is an anti-anxiety drug that has been shown to help with relaxing the top of the stomach, so that phenomenon of fundic accommodation that I mentioned earlier. And then mirtazapine is an old antidepressant that we repurpose on the basis of small trials in the gastroparesis population to help with pain, nausea, as well as weight gain. One of its major side effects that's not palatable for most of the people who are using it for its original indication, depression, is weight gain, but something that we conveniently co-opt for patients whose gastroparesis symptoms are severe enough that they're struggling to keep weight on. Prokinetic medications are what a lot of people intuitively think would be the natural solution for gastroparesis, and medicines, again, to push things through the stomach. Metoclopramide, it's worth mentioning, is the only medication that's FDA approved for gastroparesis. That goes by the brand name Reglan. It comes also with an FDA black box warning for the use of that medication consistently for longer than 8 weeks. There's a rare but irreversible side effect called tardive dyskinesia. So for that reason, a lot of people steer away from it. There are other prokinetics as well. Erythromycin is an antibiotic that we repurpose for prokinetic effect. It comes with its own side effects. It's an antibiotic by way of its original indication, so it comes with all the side effects of antibiotics. Domperidone, cisapride, those are older prokinetics from decades ago that have been taken off the market for risk of cardiac toxicity. So just to say that prokinetics, while maybe the intuitive class to reach for first, often come with the risk of side effects and not necessarily the one that I reach for first. Mechanical interventions are interesting in that they have a fair bit of anecdotal basis for their use, but not a lot of formal evidence basis. So pyloric Botox is one of those interventions that we employ to forcibly relax that muscle at the end of the stomach. If you look at the randomized controlled trial data, that intervention does not work. It's no better than sham injection of saline. Still, I offer it. The optimist reading is that the study that was done was underpowered for effect. And the effect was washed out over all patients with gastroparesis rather than the 30% or so who'd be poised to benefit because they actually have a problem with their pylorus. G-Poem is another interesting experimental intervention that's been around for the last 5 years ago or so, where the muscle of the pylorus is cut irreversibly. Too soon to say, I think, whether that's standard of care, but a lot of people use a positive Botox injection as justification to pursue a G-Poem. And then enteral supplementation, so feeding tubes, bypassing the stomach, while cosmetically unappealing, can be a nice and important safety net for patients whose nutritional status is precarious. And lastly, I'll mention that there are a few drugs in the investigational pipeline as well, including one that we're studying here at Penn. It's an anti-nauseant called tradipitant for patients with nausea in the context of gastroparesis. Moving on to the small bowel, I realize that I'm running a little late, so I feel like I'm also talking very quickly, but I'll try to be efficient. So the small bowel, pseudo-obstruction is the word that we use for slow motility in the small bowel, meaning, again, much like gastroparesis, the symptoms of real mechanical obstruction in the absence of mechanical obstruction, so pseudo-obstruction due to slowness. It can be associated with a number of symptoms, including bloating, distension, nausea, vomiting, abdominal pain, diarrhea, and malabsorption. Late stage manifestations can include something called pneumatosis intestinalis, which is gas forming in the wall of the intestine that can be a risk factor for perforation. Secondary to pseudoobstruction, independent of pseudoobstruction, is the possibility of developing diverticula in the small bowel, which are outpouchings of the muscle wall that can lead to risk of their weakness points of weakness in the wall of the small intestine. So can also predispose to perforation, but more commonly bleeding, and still more commonly a risk factor for SIBO, small intestinal bacterial overgrowth, which is what I'll talk about next. This is a hard diagnosis to make in a general population, but again, high enough in its prevalence in the scleroderma population that I think I often just presume it is active in patients with the right symptoms. And the compatible symptoms are abdominal pain, bloating, diarrhea. The idea of this entity is that everyone has a certain amount of bacteria in the small bowel that's normal. But if there's a predisposing condition for those bacteria to overgrow, whether that be disturbances in the anatomy of the small bowel, for example, those diverticula that I was talking about earlier, or more saliently in the scleroderma population, a disturbance in the motility of the small intestine, that can lead those bacteria to overgrow. And if there's too much bacteria in the small bowel, they can metabolize or eat the food before the bowel has a chance to. When bacteria metabolize food, they create small molecules that draw water into the bowels. They can create gaseous byproducts that lead to this bloating and distension. So that's the logic. There are still other potential risk factors for SIBO, including diabetes, abdominal adhesions, chronic pancreatitis, common variable immunodeficiency, but the ones that are salient in the scleroderma population are anatomy and motility. The treatment is focused on reducing bacterial burden and reversing risk factors where possible. So practically speaking, that means antibiotics. In the best case scenario, a short course of antibiotics will lead to long-term remission of SIBO symptoms. But to the extent that certain patients with scleroderma have risk factors that are fixed, sometimes we initiate cycling antibiotics. So a round of antibiotics, maybe a short holiday, and then a round of a different antibiotic just to keep those bacteria at bay. One of the potential medications that we can supplement with antibiotics to mitigate the risk factor of slow motility is a diffusely acting prokinetic. So a medication that keeps things moving through the small intestine. I'll talk about those towards the end of this presentation. SIBO has been quoted to be present in up to half of patients with scleroderma. There are formal testing modalities that can be pursued to make the diagnosis of SIBO, specifically hydrogen breath tests, but they're subject to significant interpretive limitation. In the context of scleroderma, I think the pre-test probability is high enough, meaning even before you do the test, the probability of the diagnosis is high enough that I tend to prefer just treating with antibiotics empirically. In terms of antimicrobials, rifaximin is the best studied, probably because it's still on patent, to be honest. And so the pharma company has the most vested interest in studying that drug. But it is distinguished from other antibiotics because it's gut specific. So it's not absorbed outside of the GI tract, meaning side effects are minimal. There are numerous others that are used that are much cheaper. So doxycycline, metronidazole, ciprofloxacin, I've used all of them to good effect. As I mentioned before, sometimes I end up using indefinitely cycling antibiotics in refractory cases. There are some natural antimicrobials available that I think are harmless, but they have little to no evidence behind them. So Atrantil is one that gets marketed a fair bit. GI Microbex is another one that I've used on occasion in the past. Candibactin, dysbiocide. These are all natural antimicrobials that have a lot of different components that are all herbal, but again, not much evidence to support their use. Moving on to the last part of the gut, the colon and the rectum, I'll talk a little bit about fecal incontinence. This is one of those complaints that we tend not to talk about as much as we should, just because it's often embarrassing. It's often life-limiting, just in terms of functionality. The presumption is that it is secondary to weakness of the internal anal sphincter, which is one of two sphincter muscles that overlap at the end of the colon. That is a function of the same degradation in muscle activity that can happen throughout the GI tract in scleroderma. It can be exacerbated by alterations in bowel habits, including diarrhea secondary to, for example, SIBO, or constipation secondary to slow motility in the colon. The first step that I pursue in managing anyone with an incontinence complaint is to optimize stool consistency. And if incontinence persists despite optimizing stool consistency, then we might undertake a more formal evaluation, including perhaps an anal rectum manometry, which is another catheter-based test that, instead of going to the esophagus, measures the muscle activity of the rectum and can clue us into whether there's any role for physical therapy with biofeedback to try to strengthen those muscles. If that too is unhelpful, there are some occlusion devices that have come onto the market fairly recently with some effect to occlude the rectum until someone's ready to evacuate. And then one of the more invasive options, but quite effective, is a sacral nerve stimulator, typically pursued by a colorectal surgeon. A 2-week temporary trial to determine whether or not it's effective at restoring continence, followed by, if that's the case, a more permanent implantation. Constipation, super common, just in general. The potential etiologies or explanations for constipation include structural causes, so a mass in the way, that's something that's easily identified with a colonoscopy, metabolic disturbances, so like a thyroid abnormality, slowness of the colon, which would be, one potential etiology in the setting of scleroderma, and pelvic floor pathology, so the sphincter not opening as well as it should. There are transit tests that are available for the colon, just as there are for the stomach. I tend not to use them all that much because the medications that we use for constipation are relevant whether or not someone has slow or normal motility. The way that I pursue therapeutics for constipation is a ladder approach. So starting with the low potency over-the-counter measures like osmotic laxatives or polyethylene glycol, which goes by the brand name Miralax. Moving on to safer and older prescription-based laxative medications. So I'm thinking here about colonic secretagogues, things like linaclotide, which goes by the brand name Linzess, lubiprostone, which goes by the brand name Amitiza. Tend not to be associated with that many side effects, can be quite helpful and more potent than Miralax. And then if need be, it's possible to escalate still further to prokinetic medications that affect not just the colon, but the entire GI tract. And the most recently approved medication in that class is prucalopride, which I'll talk about in a little bit more detail shortly. As I mentioned, a colonoscopy is worthwhile to consider if there are any alarm signs like blood in the stool, or if it's age appropriate and overdue in patients who are over 50. Actually, this slide is out of date. It should say 45. We recently changed our guidelines to start colorectal cancer screening at age 45. And then I do end up doing a rectal examination in my first visit with any patient who has a complaint of constipation, just to evaluate for that pelvic floor dysfunction, to see if there's any concern for inefficiency of the pelvic floor in terms of evacuation. Prucalopride, as I mentioned, is a diffusely acting prokinetic that was recently FDA approved. It does have a few more side effects than the other medications that I mentioned, including diarrhea, headache, and nausea in about a quarter of patients. To my knowledge, there's no specific data in the scleroderma population yet, but I think this is a ripe question for study, particularly given the concerns for diffuse dysmotility or the potential for diffuse dysmotility in this population. It can be a helpful medication that will hit 2 or 3 birds with one stone. Even in the absence of scleroderma, if I have a patient who has both constipation and gastroparesis, I'll often reach for this medication first if I can get it covered for that reason. If prucalopride isn't covered, since it is new and on patent, a medication that's much older and very much off-label, but that I've sometimes used to good effect in scleroderma is pyridostigmine, also called Mestinon. This is borrowed from the neurology community. They use it for a condition called myasthenia gravis. It works by making acetylcholine more available in the body. Acetylcholine is one of the body's excitatory neurotransmitters for the GI tract, so it moves things forward. It happens to do a lot of other things in the body too. So side effects include flushing, bloating, dizziness, and most significantly, I think, bradycardia or slow heart rate. So there are a number of potential contraindications. This is just a some screenshots of a study that I did when I was in fellowship at Hopkins, looking at our institutional experience with Mestinon in the Scleroderma population. And we found that symptom effects were present and good in just about half of the patients, but a number of them couldn't tolerate it due to side effects. So I'll stop there. And I think I saw a few questions come through the chat, but I'll open it up and ask if we could have a conversation.
All right, so Mark and Marie said, I recently had a capsule camera test and the pill stayed in my stomach and didn't get into my intestines.
Yeah, if I understand the test correctly, that sounds like a pill cam or a video capsule endoscopy, sometimes employed to visualize the 20 feet of small intestine that sit between the extent of our upper endoscopy and our lower endoscopy. There's just not a good way to reliably scope that anatomy. So the pill camera is a surrogate for that. It is the case that a pill camera, which is designed to record for 8 hours, sometimes doesn't visualize the entire small intestine. And sometimes it doesn't get out of the stomach at all. And so that would be some concern for gastroparesis. The workaround that we sometimes employ in our practice is to do an endoscopy and deploy the pill camera in the small intestine deliberately. So I can't speak to your clinical case, but that would be what we would do in a vacuum.
Okay, thank you.
And the next question was, does the need for increased acid suppression increase the risk for esophageal cancer?
Yeah, it's a good question. I don't know that I might reformulate it slightly to say, does increased acid exposure increase the risk for esophageal cancer? And the answer is likely yes there. The phenomenon of long-term acid exposure to the bottom of the esophagus can, in certain susceptible individuals, lead to a condition called Barrett's esophagus, also called intestinal metaplasia of the esophagus, which is a precancerous condition. The rate of transformation to intestinal metaplasia and then from intestinal metaplasia to dysplasia is in aggregate quite low, but it's one of the reasons that we try to suppress acid aggressively when we suspect it, whether that be on the basis of clinical history or with an endoscopy suggesting erosive changes that would be consistent with acid reflux.
Okay. We have a couple more questions on the chat. Someone is asking, are there any natural remedies for gastroparesis and severe constipation?
It's a great question. I will take them separately. So gastroparesis, there are a couple of herbals that I think about, particularly in the context of that coin where, one side is gastroparesis and one side is more functional nausea, vomiting, dyspepsia. There are a couple of herbals that have been looked at in the functional dyspepsia population specifically. And I think there is some potential for crossover benefit, but I should say it hasn't been studied in gastroparesis. So the two herbals are FD Guard, which is a combination of peppermint oil and caraway seed oil that has been studied in the functional dyspepsia population and found to be beneficial for people who have abdominal pain and nausea after meals. And then the other one is called Iberogast, also called STW5. That's not manufactured in this country. It's actually manufactured in Europe, but it's accessible on Amazon. And there too, it's been studied against placebo in the functional dyspepsia population, found to be helpful for abdominal pain and nausea after meals. For constipation, in terms of natural remedies, I think diet, there is a fair bit by way of dietary interventions that folks can do to ameliorate constipation. There are some laxative foods, things like aloe juice, papaya, prunes, fiber in general, which could take the form of soluble fiber supplementation, or fiber-rich foods, things like flax seeds or chia seeds. I have patients who have enjoyed good benefit with those interventions.
Thank you. Okay, I don't know if it's Baclofen interfere with the absorption of PPIs?
It's a good question. Not to my knowledge, but I'd be interested to hear more if you had been told by someone that it does. We often talk about it as a useful adjunct for acid reflux patients who are already on a PPI. So I think of them as compatible drugs.
Okay, and if you ask that question and you want to unmute, you can. The next question was, what are your thoughts on glycerin suppositories for constipation?
Yeah, I think it's a fine option. I tend not to recommend glycerin suppositories on an ongoing basis. Just they can be stimulating, and I think per-rectal therapy is just, all comers. I wouldn't imagine the preferred approach for a maintenance regimen. If I have a patient who is reporting that suppositories and enemas are the only thing that help, and really everything oral doesn't work, I think that too can be kind of a clue that there may be something with the pelvic floor that's contributing to the pathology.
Okay. And can you recommend a good diet plan or website with good meal plans?
I guess I'm reluctant to recommend a diet across the board for scleroderma, or at least I wouldn't know one. I think from a GI perspective, it's all tailored to symptoms. So depending on the segment that seems to be involved, there are gastroparesis diets, there are, as I mentioned, some constipation specific diets. SIBO diets tend not to be really well validated, but there's stuff on the internet about that. I tend to take that with a big grain of salt. For folks with irritable bowel syndrome, there's a diet called a low FODMAP diet that has been well studied, but I think having a diagnosis of scleroderma essentially precludes a diagnosis of irritable bowel syndrome. That, more likely than not, it has something to do with the background connective tissue disease. So hard question to answer. I think it would be tailored to the patient.
And Kathy, if you have any specific, I'm reading your question, and it looks like she's, I guess, why there aren't more medical professionals that are trained in scleroderma and the different symptoms. So
Yeah.
if you have more related to that, you can unmute yourself and ask the doctor. Mm-hmm.
I hear the frustration in it, and I empathize for sure. I think, it's a combination of it being a rare diagnosis, and frankly, just a lot of problems in the history of medicine with regard to how patients, and I think, I detect some indication of gender disparities in your question, and I'm right there with you. I think historically, we've studied a lot of diseases in the context of one gender alone, and that's done a disservice to the other. There's all sorts of biases about psychosomatics. I call myself a neurogastroenterologist, which refers to the brain-gut axis. I feel like the sort of conceptual shadow in the history of medicine is psychosomatics, this idea that the body's manifestations of illness are only in the head. And that's been a really long and unfortunate shadow in the history of medicine that some of us are working against. So, that's not really an answer to your question, but just a bit of empathy.
Right, a few more. Does impaired fundic accommodation give the sensation of chest pain, and how can this be relieved?
I don't know that I would make that connection. I think impaired funding accommodation, I usually associate with that early satiety feeling, the feeling of fullness. So there's just not enough room after a meal, or as much as there should be. Chest pain, I might think of as more sort of reflex mediated or sensory neuropathy mediated, but it can be tricky.
And do the cardiac risks of domperidone outweigh the benefits of gastric emptying?
That's a really good question. I think this becomes more of a value judgment for both the provider and the patient. We at Penn have made the value judgment as a group, as a motility group, that we feel uncomfortable enough with the cardiac risks, which are rare, but uncomfortable enough with them to not offer domperidone. Domperidone requires an investigational new drug application or an IND application to prescribe in the United States. So it's only available at select centers. That being said, there are patients who go to those centers and with full knowledge of the risks, and in light of their personal experience, having tried multiple other agents, domperidone is the only thing that works for them. I can't argue with that. So I think if you're in the hands of a provider who can offer it, and you've had a candid conversation about the risks and the benefits, then it just comes down to that calculation.
Okay, thank you. Are there any meats better than others for easier digestion?
So yeah, this is also, I think, a tough question to answer with a broad brush. And even in the context of like gastroparesis diet recommendations, I find that there are so many patients who deviate from what I expect to be true by the rubric. But according to the rubric, leaner meats, so meats that aren't as fatty, would be better tolerated than fattier meats. And things that can be brought to a consistency that's thinner. So ground meats as opposed to the opposite. But again, just a rubric.
Okay. And what do you suggest for diarrhea with weight loss?
It's tough. I mean, I think, given all of the entities that I described, it's still possible to get something other than scleroderma related diarrhea. So the usual broad differential for diarrhea still applies. And so if I were seeing someone with a diarrheal complaint for the first time, I wouldn't be neglectful of just ruling out the common things. So like an infectious diarrhea for someone who's been having symptoms for only a few weeks. If it's chronic and if there's no evidence of an infection, there are other stool tests that you can do to more formally characterize the diarrhea. But it would the scleroderma population would be enriched for small intestinal bacterial overgrowth as an explanation for that. So antibiotics would be worth a try, I think, if a patient hadn't been exposed to them already. The weight loss question is also complicated. I mean, I think weight loss can be a herald of something more sinister. So making sure that someone's up to date on their age-related screening exams, and then taking a careful history to find out if the weight loss is related to not taking enough in, or not being able to take in the right amounts of food. And so working on supplementing either appetite or the capacity to eat would be probably my back of the napkin approach.
Okay. Oh, and someone suggested venison when you were talking about the different meats that might be easier to digest, or it might be a question, is venison easier to digest?
I'm a pescatarian, so I can tell you.
Okay. Okay. Someone is taking Nexium 40 milligrams twice a day and still has chest discomfort and tightness. So could this be related to diet, and could drinking cold water cause esophageal spasms?
The question of diet is interesting. There, in addition to the behavioral stuff that I mentioned for reflux, there are some dietary triggers that people think are associated with acid reflux in certain patients, but they haven't been proven by the data. But anecdotally, there's just a common theme that tomatoes, tomato sauce, citrus, peppermint, coffee, tea, alcohol, all predisposed to acid reflux. So that would be one potential connection between diet and ongoing heartburn. But as we talked about, the scleroderma population is just predisposed to reflux by virtue of weakness of the esophagus. So it may not be the fault of anyone's behavioral regimen that Nexium doesn't cut the mustard. With regard to cold water causing esophageal spasm, that is a correlation. Spasm is an interesting word in that it means something specific in the context of manometry. So that, again, that catheter-based test that's performed to evaluate esophageal physiology, it refers to an early contraction. That can be associated with chest pain as well. But a manometry is only max 30 minutes long. So if we capture the spasm, great. Otherwise, it's possible that we just haven't caught it. When we do find esophageal spasm, it often is cold temperature intake that provokes it. It's just hard to prove in the absence of that test data.
Great. And then are there any recommendations to relieve esophageal spasms, or what feels like the spasms after eating?
Yeah, there's not a lot of obvious data-based interventions for spasm. The ones that we sometimes use just anecdotally are antispasmodic medications. So things like hyoscyamine or dicyclamine can sometimes be used. Peppermint has some data for spastic esophageal disorders, peppermint oil, which is in FD-GARD, but also in a compound that's made by the same company called IB-GARD. There are some folks who use antihypertensive medications, blood pressure medications to reduce spasm in the esophagus, but that comes with the risk of lowering your blood pressure. Just a few thoughts that I would consider in a vacuum for someone who had a spastic esophageal disorder.
Okay. What therapies beyond PPIs would you recommend for someone diagnosed with Barrett's esophagus?
So PPIs are the mainstay. PPIs are the only hard and fast recommendation for anyone with Barrett's as chemo prevention, meaning a medication that you can take to prevent progression to cancer. Otherwise, it's surveillance endoscopy. So surveillance endoscopy meaning taking a look every 3 to 5 years to make sure that the Barrett's is not progressing. There's some more marginal data about the use of aspirin as chemo prevention. It's marginal because while there is an effect on reducing transformation, the rate of transformation to cancer, it comes at the cost in aggregate of increased risk of GI bleeding. So that's why it's not formalized as a recommendation.
Okay, thank you. Do you recommend a food diary for 6 months to determine certain trigger foods?
I'm always a fan of diary keeping. I think as we live our lives, it can be hard to figure out patterns. I think 6 months may be a bit long, but it's kind of individualized depending on how much your day-to-day varies. If you have a lot of baseline variability, 6 months could be a helpful timeline. But just starting with a few weeks, I think could tell you maybe if it's going to be a fruitful exercise. Not everyone has trigger foods though for their symptoms. So it may not be the case that a pattern emerges.
Okay. Someone said, my husband has been on TPN for over a year this time and cannot tolerate food at all. Have you seen patients eventually work their way back to maintaining weight without TPN?
I have. It's tough. It's a tough intervention to pull back from. And TPN comes with all sorts of risks. And so I share most patients' ambitions to come off TPN. There are a number of medications that I mentioned that can help with symptoms in patients with GI dysmotility in general, not just scleroderma, but it's not an infinite list. So, we try our best and sometimes we're able to do it, but not always.
I'm not sure. So someone wrote trigger allergy foods such as nightshades, gluten, dairy are probably the most mentioned. I think that's probably back to another question. Okay. Are you familiar with the use of Interface Plus enzyme supplement with dietary supplement antibiotics for SIBO? If so, is it safe?
I'm not familiar with that agent. I don't know that I could even lump it under the category of the natural antimicrobials that I mentioned earlier, just because I don't know what's in it. So I probably can't answer that question.
Okay. And yes, I'll answer. You will receive a recording of the program. I'll be sending it out. And this question for you is, what is a Stiltz X-ray?
I think that's SITS X-ray, so SITS
Okay.
marker. That's a transit test for the colon, where you swallow a tablet that has 24 radiopaque markers in it, little circles. And you get an X-ray at day 1 to confirm that you actually ingested the capsule, and then again at day 5. And at day 5, if you have more than 5 of those capsules still in the body, that is an indication of slow transit in the colon. Sometimes we can use it as a clue for pelvic floor dysfunction as well. So if all those markers are still in the body and clustered at the very end, that suggests that the colon is not slow as much as there's a problem at the outlet, not letting those markers out. But it's a transit test, and it's a cheap transit test. I don't order it very much, as I mentioned, because I think it doesn't really change my management. If someone's constipated, I believe them, and all the therapies are the same, whether or not the SITS marker is abnormal.
Okay. Is the incidence of rectocele high in scleroderma patients?
It's a good question. I don't think of it as higher. Rectocele is an outpouching of the rectum, usually anteriorly, so forward in the body. That can be another cause of constipation related to evacuation at the outlet primarily. It's a form of pelvic organ prolapse. I think of it as more common in patients who have a predisposition. 1 second, sorry. I'm giving a talk. Sorry. So prolapse, more common in patients who have risk factors for prolapse, including, for example, multiple childbirths. I think of it in tissue laxity disorders. So like Ehlers-Danlos, for example, or descending perineum syndrome. I don't actually know the answer. It's a good question. I'll look it up for myself.
Someone's been diagnosed with limited scleroderma for 30 years with predominantly GI issues, and she wants to know if it will get worse as she gets older.
That's a good question. I tend to think of the natural history of scleroderma as unpredictable. There are patients who stay stable where they're at, and there's some people who decline in a stepwise fashion, and it's hard to know when those declines are going to happen. I think medications can lead to an upswing in functionality, but in general, there's not. I don't usually think of scleroderma function as restoring spontaneously, or GI function in scleroderma restoring spontaneously. So it's hard to predict how things are going to go. I don't think that there's a lot of value in being reconciled to the idea of things getting worse, though. So it's very possible things will stay the same.
Okay. What do you think about the genetic testing being done to determine food sensitivities and allergies?
I'm not familiar with it. I know that there are allergy-based tests that involve skin testing, and their blood tests to look for antibodies. Those are not great because allergies are distinct from intolerances. meaning a traditional allergy like a hives kind of reaction, or your throat closing up. Those are the sorts of things that are picked up by allergy testing. Intolerances tend not to have very good tests associated with them. I don't know much, if anything, about the genetic tests that are being invoked, but I suspect they're sort of peripheral to external to the sort of traditional biomedical practice that I'm involved in.
Okay. How much of a factor do you feel stress plays in GI?
In GI generally, I think it's a huge factor, potentially. The idea of the brain gut axis, I think, lays that bare. The metaphor that I learned from a psychologist in my fellowship who used this metaphor that I think is apt. She describes stress as kind of a volume knob for symptoms. So the signal is the signal, but it can be rendered louder or softer based on the presence or absence of stress. The signal, there's no question in patients with scleroderma, the potential for that signal being structural or organic is there, but stress can make it louder.
Okay, good. If pantoprazole does not help with someone's reflux, why would a physician recommend to take a second dose instead of changing the protonic medication altogether?
It's a reasonable question. The dosing for PPIs generally tends to range from 20 milligrams once a day or even 10 milligrams once a day to 40 milligrams twice a day. So some physicians will say before we exhaust a certain agent as an option, we should max it out just to see if increasing the amount of acid suppression helps with symptoms. A recent study that was done 2-3 years ago now looked at the relative potency of these medications and did find that pantoprazole was probably the weakest of them. Prior to that paper, I used to think that they were all roughly equivalent. Pantoprazole was about a quarter as effective as omeprazole, and Nexium and Dexilant, which are brand names, are still more potent than omeprazole. So there'd be wisdom in, I think, transitioning to another agent as well. I too probably would proceed stepwise though, like try to max out an agent before moving on to another.
Okay. How do you recommend optimizing stool consistency for fecal incontinence?
So it depends on whether the baseline consistency is diarrheal or constipation. If there's diarrhea, we try to address it in the ways that we talked about earlier. The bluntest maneuvers that we have to mitigate diarrhea would be anti-diarrheal medications like Imodium or Lamodal. If there's constipation, we would go up the ladder of laxatives. We have a stool scale that goes from 1 to 7, 1 being super constipated, 7 being entirely water. And so the goal is to get us to kind of the median, the 4, which is a well-formed, soft, complete bowel movement. If incontinence persists at the Bristol 4, that's when we would undertake those physiologic studies.
Okay. Have you ever heard people with scleroderma having GI flares or side effects after receiving the COVID-19 vaccines?
I don't know enough about it. I have heard at least one of my patients with connective tissue disease say that she's had a longer reaction than has been pitched as standard, like 24 to 48 hours. Hers lasted several days. I'm really humbled to the fact that COVID is a new phenomenon, as is the vaccine for COVID. So to my knowledge, this has not developed into a pattern that's been published yet, but we don't know. We don't know.
Okay. And have you seen changes to scleroderma with menopause or HRT?
I assume that's hormone replacement therapy, and I haven't, but that doesn't mean it doesn't exist. I just my focus ends up being GI, and that often comes at the expense of like a GU history or genital urinary history. So maybe I'm not asking about it.
Someone just said they had a second shot of COVID and no side effects. So that part's good. Question, for someone with Barrett's esophagus and asymptomatic GERD, which PPI would you recommend? And they said they can't tell if the pantoprazole is effective since they're asymptomatic for GERD.
It's a good question. It's hard to answer this question specifically with regard to a specific patient, but the guidelines for Barrett's esophagus don't split hairs among the PPIs. So any PPI should offer enough chemoprevention to yield the benefit. The way to know, I think, would be to do formal testing. If you were really curious, to take a look and make sure that there's not any erosive changes overlying the Barrett's. If there's not, then it's probably doing a decent job. The more specific test would be the catheter-based test to formally quantify how much acid suppression is happening in the esophagus. But in general, I tend to leave it at daily PPI is covering the risk of Barrett's transforming. I mean, it can still transform, but a daily PPI is all the guidelines recommend and all that I recommend as a result.
Okay. That was all the questions in the chat, so thank you very much.
My pleasure.
Katie?
Thank you so much, Dr. Ahuja. I really appreciate you taking the time to speak with us today.
Yeah, it's my pleasure. Thanks so much for the invitation.
Very good. If we get any other questions, can I email them to you?
Sure.
Okay, very good. Now, he can't answer like medical advice. He's not allowed to give medical advice. So, it has to be like a general question. But if somebody has another question, you can send it to me through the Scleroderma email, which is K Higgins, Higgins, at scleroderma.org. And I'll send it on to Dr. Ahuja. And that's for like the next month or so, okay? Not forever. Thank you so much, Dr. Ahuja. I really appreciate you coming and speaking with us tonight.
It's my pleasure. Have a good night, everyone.
Have a good night, everyone. Thank you.
Thank you.